Hello, and welcome to the March 2024 issue of IGIE. My name is Phillip G, Section Editor for IGIE's section on Historical Considerations. It is important to understand the past in order to foresee the future. In the world of interventional endoscopy, there are many who have pondered the future of endoscopy, but very few whose predictions have accurately translated into reality. Those are the true disruptors and pioneers of our field, with the enviable ability to turn whatever they touch into gold. While every young, passionate endoscopist aspires to become a disruptor and pioneer, very few possess the ability to successfully disrupt and pioneer an entire field, and even fewer are able to continue doing so throughout the course of their career. We are therefore delighted to have the opportunity to interview Dr. Kenneth Chang as our distinguished guest for the Historical Considerations section of IGIE. Dr. Chang is one of those very special few who have possessed the ability to peer time and again into the crystal ball to anticipate the future of our field. Being first to coin the terms interventional endoscopy and interventional EUS in 1997, Dr. Chang has continuously introduced disruptive technologies to our field, including EUS-FNA for tissue sampling, RFA for the treatment of Barrett's esophagus, endoscopic treatment of GERD, and EUS-guided portal pressure measurement for patients with cirrhosis. Along the way, these technologies have added entire sections to the world of advanced therapeutic endoscopy or interventional endoscopy. Dr. Chang is currently Professor and Chief Emeritus of the Division of Gastroenterology and Hepatology at the University of California, Irvine, and the Founding Executive Director for the Chow Family Comprehensive Digestive Disease Center and Digestive Health Institute. Dr. Chang, thank you so much for taking the time to provide this interview. It's truly an honor and privilege. Tell us a little bit about your own background and your own training in endoscopy.
Philip, thank you so much for this interview and this opportunity to share a little bit of my journey. I started at Brown University, and I did my undergraduate and medical school in their 7-year program, class of 1985. So you can figure out how old this guy is. And then I did my internship and residency in Rhode Island Hospital, which was Brown's teaching hospital in internal medicine. Then after that, I went across the U.S. And landed at UC Irvine to do my GI fellowship, 1988 to 1991. And then after graduating from the fellowship, I started as a junior faculty at UCI's Long Beach VA. And I was there from 1991 to 1993. And that's where I self-taught EUS and developed EUS-FNA. And we can talk more about that later. Then in 1993, I moved essentially across the street to the University Medical Center, where they recruited me to be head of GI oncology. So that was an interesting thing. So from 1993 to current day, 31 years later, I still serve here at UCI Medical Center. So the longer you stay, I guess they keep promoting you.
Sounds good. And actually, you're talking about 1985. Born in 1985, so that gives you a sense of my age. Dad.
Okay. Son.
When you were in training, though, endoscopy and actually interesting endoscopic oncology, I guess, or GI oncology, was very limited in scope still, and was a very small part of gastroenterology. So what specifically led you to become interested in endoscopy?
Yeah, in 1983, I was between my 3rd and 4th year of medical school. And I decided I was way too young. I was on the accelerated track, and I needed to grow up, mature a little bit, see the world, and maybe, serve an underserved population. So I took a year off between 3rd and 4th year of medical school, which was at that time kind of unheard of. My Asian parents were worried I wouldn't have a seat back when I returned. But anyway, I spent that year working in areas in Asia, specifically in inner city Hong Kong, at a hospital called Evangel Hospital, and then most of the time in a small fishing village in the southern tip of Taiwan. This is a village, an area, province called Taitung. And there I was working with 4 missionary doctors, 2 surgeons, 1 internal medicine, 1 peds. And that's where I just learned by watching these amazing people continue to innovate out of compassion, because the people were desperate, they were under-resourced, and they had to rig up everything. And so it was there that I caught the innovation bug. It was there that I did my first endoscopy as a medical student.
Wow.
I was in the OR one day, and they got this second, third-hand fiber optic scope, and the surgeon said, "Hey, let's take a look." And I was looking through the fiber optic and fascinated that we can see inside the stomach through this device. And so that was my first exposure and doing an endoscopy as a medical student. Then when I came back, I graduated, I did my internship residency at Brown's Rhode Island Hospital. For my second year residency, there was an attending, this cool guy, his name was Joe DeMacy. He said, "Hey, you seem pretty facile. You want to do a colonoscopy?" And I said, "Sure." And I almost got to the CECM as a second year resident. He said, "Not bad, dude." So anyway, that was when I fell in love with endoscopy.
That's amazing. And, it's funny how hindsight works. But I was going to ask you, like, when you look back on your younger days, or let's just say even before you went into medicine, in hindsight, did you always possess the gift of foresight? Or kind of what inspired you to develop that foresight or become the pioneer that you are?
Yeah, I do think, for me, I assumed everyone saw things the way I saw it, but it became obvious to me not everyone does. And so I do believe it's a gift, but a gift that requires cultivation.
Mm-hmm.
So as a child, I was what's called a daydreamer. Like, my mom would catch me all the time. I'd be like sitting, looking out the window, just wondering about how the world works and all kinds of things and all kinds of possibilities. And she would catch me daydreaming, and she would say, "Son, hey, come back to the real world." But that daydreaming part of me has never really left me. We call it now the alternate universe. So as I'm talking to you, I could be living in my alternate universe at the same time. Depending on how much attention you need, I'm more focused here than my alternate universe. But if I'm like at a kid's graduation and there's 50 other people getting their diplomas, I'm in my alternate universe. And most of the time in that alternate universe, I'm somewhere in the GI tract. I'm looking at organs. I'm flying through, this bowel and that bowel. I'm connecting this space with that space. I'm asking questions and the what ifs. So that has been nonstop my whole life. I think living in this alternate dream world, thinking, innovating, I think. And so to this day, my wife catches me and she'll say, "Hey, come back to the real world." So
she's taking over.
Taking over. Yeah, but I remember as a child, we didn't have money back then, and not a lot of toys. So I would make my own stuff. I built a whole arsenal of weapons by putting together pieces of wood and making bows and arrows. So I think I was a tinkerer. But I think it's this other mindset, being able to see things. It's kind of similar to the gift of leadership. I think to be a leader is to be able to see someone when they're young and actually see the best version of them in the future as if it's now, and encourage them towards that future best self. So it's being able to see as if it's real. So I think sometimes when I think of techniques and technologies, I actually see it as if it's real. Now, obviously, there's lots of steps between here and there.
Sure.
In my alternate universe, I'm seeing things into the future.
I see. No, that's very well said. Actually, I don't think I've ever heard anyone describe it in those terms. It really is a gift, I would say, and it's the gift of being able to see into the future. Just kind of like it's funny you talk about leadership. I've always known you to be an exceptional judge of character, and I think that kind of plays into this as well. So yeah, let's talk about history then. So you were fresh out of fellowship, starting off as a junior faculty. And nowadays we look back and we say that in the late 90s, I believe it was 1997, I think with the power of dreaming, you were credited to be the first to coin the terms interventional endoscopy and interventional EUS, terms that are broadly used today. Tell us about what existed at the time. What was the endoscopy landscape at the time, and what kind of led you to coin these terms? I imagine there was a significant technological gap between dream and reality at the time.
Yeah, very much. So let's put on our 1990s hat and go back in time. Around that time, flexible endoscopy was mainstream. We moved from fiber optic to video. That was a real, breakthrough. ERCP was just kind of, getting its stride. And then we called that therapeutic endoscopy. But as we were developing EUS around the mid 1990s, we had established FNA, and we were starting to explore FNB, EUS FNB. We just started the concept of fine needle injection with celiac neurolysis, anti-tumor agents. We were using EUS to place guide wires. We started to do EUS pseudocyst drainage at that time. And so I spent a lot of time in interventional radiology. At that time, IR was also very, very new. And I was watching my colleagues, and they were passing guide wires, and they were taking biopsies of the kidney, and they were accessing different things. And I'm like, therapeutic endoscopy doesn't capture the breadth and depth of what we're doing and what we can do. And so I was looking at interventional radiology, and I was looking at interventional cardiology. I'm like, why not interventional endoscopy? Why not interventional GI? Could the future have enough there that we can be a subspecialty? And so, and then Moritz Wiersma and I then wrote the paper that published in 1997, coining the term interventional EUS.
Wow. And bold statement, actually. I'm sure in 1997, when you guys wrote that paper, you probably, I don't know if you had any bit of doubt in your mind or a bit of doubt in your heart, but, if you kind of put on your 1997 hat, right, and you kind of sit there and think about this, that's very disruptive. You have to take a tremendous amount of risk and courage to make such disruptive publications or disruptive advancements. And so in those early days of your career, did you ever have doubts about the future? Did you ever wonder to yourself what would happen if this just did not pan out?
So in my alternate universe,
right.
I see trends, I see pathways into the future. And in that alternate universe, there's no risk, right? Because you're dreaming. But then when in reality, now you're looking at medical legal and IRBs and lawsuits and
the business environment.
Criticism from colleagues, criticisms from other specialties and so on. So in reality, you rarely make big, bold jumps or leaps. That's too risky. So in reality, even though you see the path forward, you take incremental steps. You build on your prior experiences, and that's why the older you are, the more experience you can be building on top of, right? So you build your prior experiences. You often wind up combining things that you've learned in the past, A with B, and sometimes A, B, C, and D, and you combine them to create a new thing, but it's actually a combination of old things.
Right.
And then you also realize that there are really two pathways in with innovation. One pathway is there's a problem, there's an unmet need, and you're thinking about how do we solve this? So a problem that needs a solution.
Mm-hmm.
But the second pathway in innovation is you're handed a solution, and now you're looking for a problem to apply it to, right? So
Right.
sometimes people hand you, or you see a technology, and it's like, oh, but let's kick the tires and see what it can do here, or what it can do there, and what it can do there, and then finally you see a match, or you don't, right?
Right. There's plenty of those
Right.
examples.
Yeah. So I think doubts in the alternate universe, no. In the real world, practicality says incremental steps, so that your risk is minimal.
Mm-hmm.
And always be willing to learn from your failures. I can write a book on all my failures, so it's not that, and you
Right.
learn from them. And then work collaboratively with your colleagues and other colleagues, across the globe. And so that makes it fun, and that keeps it exciting. But yeah, so minimize risk, and it's harder and harder to do that.
Right.
I mean, I didn't realize back in the 90s those would be that's the wild west of innovation, because you don't know that things will get tighter and tighter into the future. But
Mm-hmm.
it's harder today as a young investigator to do something, new and novel, because especially you don't have experience. If it's the very first ever and you screw up, you don't have a leg to stand on,
Right.
and so it becomes hard. And then IRBs are harder and more stricter. Regulatory issues are harder and stricter. Off-label becomes more difficult. Reimbursement becomes an issue. So
Right.
it definitely is harder to innovate today than it was back in the 90s.
Got it. And so I guess with that context, let's talk a little bit about the beginnings of interventional EUS. So it was easier back then, I guess. But as I understand it, what's not really disputed is you were the first to perform EUS FNA in the United States. That's a big one. How did this come about?
So back in the 90s, there was no internet. There was no web. There was no literature searches. Everything was, go to the library and see if there's an article. But anyway, there were 4 of us in the world that kind of almost simultaneously were thinking along the same way and published around the same time. So the 4 pioneers of EUS FNA, 2 were in Europe and 2 in the United States. The 2 in Europe was Peter Vilman in Denmark. He was actually the first in 1992 to report a case of EUS FNA of a benign pancreatic lesion. Then Mark Giovannini in France was also one of the 2 pioneers in Europe. And then in the United States, Moritz Wiersma, who was at that time mentored by Rob Hawes at IU, and then myself at UCI. So the 4 of us independently were thinking and dreaming along the same lines. And so in 1994, we published the first case of a EUS FNA of a pancreatic cancer. And then our case series of 34 patients was also published in 1994. And then the 4 pioneers collaborated and put together the multi-center experience with EUS FNA, and that was published in Gastroenterology in 1997. So this was truly people who had been doing EUS, working inside the GI tract lumen, imaging outside, and wondering what if. And with the development of the linear array echo endoscope that what if became, oh yeah, we can pass a needle through. I think the perspective that EUS gave us then, and what EUS gives us now, as you appreciate, is as a general endoscopist, you're always looking at mucosal surface. But as an endosonographer, you're looking on the mucosal surface, you're looking in the wall of the GI tract, and you're using the GI tract as a window to see all of the organs outside.
Mm-hmm.
And it's this paradigm that really is really the breakthrough.
Mm-hmm.
The FNA was great, but the real breakthrough is a mind shift to now think of the GI tract as the outside world's access to the inside world.
Mm-hmm.
The way to think about it is, back when we were embryos, we were nothing but a blob with a tube. Mm-hmm. The outside world connected with your inside world through that tube. That tube became the alimentary tract. So essentially, your GI tract is your inside skin. Right. So if you think about it that way, if you go inside your alimentary tract and you're actually looking through the body from the inside skin, but in the same way that from the outside, percutaneously, we can put needles in and get to various organs, how much better can we get to those organs through the inside skin? And so that mind shift of being able to image and access organs through the inside skin is the real mind shift and paradigm shift that was the true breakthrough. Because then the needle is not just a biopsy tool. Right now you've got access, and you can deliver, and you can connect, and you can create anastomoses, and you can ablate, and you can put heat, and you could put cold, and so that was really the game changer for me.
Right, and basically, essentially, that needle became the modality to which you would explore your dreams, basically.
Exactly.
So tell us about some of those early devices and early needles. I would imagine not very many companies made them. Tell us a little bit about the early technology.
Yeah. So I was at the VA between my last year fellowship and my first year as junior faculty. There's this sales guy named Bob Anderson who came to the VA, and he said, "Hey, I work for Hitachi, and we have this new Hitachi Pentex EUS scope, and I hear that you're the EUS guy in Southern California." I wasn't going to deny it, so I said, "Yeah, sure." As a fellow, at that time, I was just learning EUS and literally teaching myself. Mm-hmm. There were no courses. There was nothing online.
Right.
There were no CD-ROMs. So teaching myself by spending lots of time. These veteran patients were very cooperative. They would let me do an EUS examination for 60 minutes while they're sedated. And so that I had a chance to learn the anatomy and so on. Mm-hmm. Took me, 20 exams before I found the pancreas. Mm-hmm. But anyway, so I was doing EUS, and Bob Anderson comes and says, "Here's this new echo endoscope, but it's a linear array." So all we had back then was mechanically rotating radial scope. Mm-hmm. So with the linear scope, I said, okay, that's interesting. You can see things from a different slice, a different perspective. And I noticed that there was a biopsy channel, and I asked Bob, I said, what's the biopsy channel for? He said, "Oh, I don't know. I guess you can do pinch biopsies of the mucosa while you're there." And I'm like, wait, what if you put a needle through the biopsy channel? Could you see the needle on ultrasound? He said, try it. So then that was the beginning. Again, everyone has their stories, but my story is I was handed the scope with a channel, and as soon as I put a biopsy forceps through the channel in a water bath, I could see the entirety of the biopsy forceps on the EUS image. And so back then we had no needles, right? So I borrowed a Wang bronchoscopy needle, and the Wang needle was 1 centimeter long, and I could see it entirely on ultrasound. So then we got a hold of some prototype needles. There was one by Pentax, there was one by Cook, there was one by GIP Mediglobe, and those needles were really rickety. They were 2 centimeters, and then 4 centimeters, and then 6 centimeters. But some of the early version needles was like a needle that was screwed onto a Teflon tube. And so you push the handle, and the Teflon tube would push the needle out, and it would barely go out. But then when you try to retract it, it wouldn't retract. So we killed a lot of scopes back then. I even dropped a severed needle in a patient once, and I had to go back and fish it out with an endoscope. So those were the real Wild West days on FNA development. And
yeah,
I don't know, it took a good decade to come up with decent FNA needles back then. So Cook really took the lead in terms of developing the FNA needle, and then the conversion to FNB.
Sure. Very, very interesting that you were handed a linear echo endoscope. Any historical perspective on why? Like, did somebody else anticipate that you would use this for therapeutic purposes?
No, I
think
kind of
it was messing around with different ways of looking with an ultrasound.
Yeah, I think it was just in the ultrasound world, whether it was transanal or transesophageal echo, it was there were probes out there that were rigid probes that were linear oriented or radially oriented, depending on what kind of imaging they needed. So the first echo endoscopes were all radial oriented, and they were rotated mechanically with a spinning cable. The piezoelectric element rotating around in this oil chamber to keep it lubricated, and sometimes it would get stuck and not rotate. But anyway, so those were the early days of one piezoelectric element that was rotated around, so you can, and so the view would be like a radar, like it would you could actually see it spin around sometimes, forming the image.
Right.
And so those are the early days. But the linear array came out not intentionally for FNA, but it just kind of came out as a different orientation of ultrasound. And the FNA was developed after it got into people's hands.
Interesting. Yeah, it's very interesting. I mean, you kind of wonder, like, if the inventors of linear ultrasound felt like there were certain organs that were better visualized with it, or what. It certainly gets into the questions of how this technology came about. And by the way, I actually found this in my office the other day. It's a book.
That's right.
On linear EUS. This is from, from the year 2001. There you go. The Atlas and Manual for Use in the Upper Gastrointestinal Tract, Longitudinal Endosonography by T. Roche, U. Will, and K. J. Chang.
That's right. Yeah, I mean, back in the day, training was horrible. And trying to learn anatomy for EOS was, I spent about 6 months, in radiology, just learning transabdominal ultrasounds, the early days of CT. MRI wasn't there back then, but just learning the anatomy alone, and then learning the anatomy through this weird orientation that we put ourselves in with EUS.
Right.
Yeah. And again, back then there were no resources. my colleague Rick Erickson, who just recently retired, he was masterful at creating these figures and diagrams on PowerPoint that I still use today. I mean, they're very accurate, and so in the early days, our challenge was to be able to recreate the anatomy so that the EUS learners can have an easier time mastering the anatomy than it took us, decades to master.
Right. And now they try to squeeze it into a year.
That's right.
Along with everything else, of course.
Exactly.
Now, when you did your first EUS FNA, I'm sure there was a whole mix of excitement. Did you realize at the time that you were about to change an entire field for generations to come?
Yeah, I don't think I saw it that far-reaching, but like I said, I think the excitement in my alternate universe, I would be thinking and dreaming of all the things that I could. I mean, crazy things like put the EUS into the back of the soft palate, an image into the sinuses and access the sinus, or from the esophagus, put something into the pericardium, drain pericardial effusion. I mean, in my alternate universe, I was accessing and needling like everything, right? But when we finally did our first, my very, very first FNA was a mediastinal lymph node, and I was scared to death because I had no idea. And, so that's the risk, right? When you finally you've dreamt about it, you've thought about it 10 million ways, and you get to finally do it on that day, you're sweating bullets. And then you're thinking, what if the patient dies? My career is dead too,
Right.
Or what if there's a complication, of course. Yeah. But anyway, so I think once we realized, it can be done well and safely, and we had predicates, right? The interventional radiology, even back then, they were sticking big needles, through stomach and bowel to get to the pancreas, to get to the liver, to get to the kidneys. They were just sticking through a lot of things. And watching the IR folks do that, I'm like, the GI tract is like a Michelin tire. Like you can stick a nail through a Michelin tire and nothing happens, right?
Right.
So then understanding all of that, putting a 22 gauge needle through the esophagus then became okay. But anyway, it was still scary first case.
Sure.
But I think the real aha, wow, the thrill and the excitement is that paradigm that I dreamt about for years. Finally, it became reality, right? And others were doing it, and we had a series of patients showed great safety, and so then we knew we were onto something. Yeah,
absolutely. And looking back now, I mean, several decades later, what do you think have been subsequently the most impactful advancements in the field of EUS from both the basic imaging all the way up to an interventional standpoint?
Yeah, I think from imaging, the major breakthroughs have been moving from radial to linear, like we talked about. And then back then, again, the ultrasound imaging were really crude, and it looked like snowstorms most of the time, where you can barely see anything. So improving ultrasound clarity, improving ultrasound penetration, and now all kinds of image enhancement modes that are available, so we can see things so clearly, and we can rewind and frame and go back frame by frame, and we can put on Doppler and E-flow and get harmonic ultrasound, contrast ultrasound. All of that helps with our imaging. And then the scope itself, we needed larger channels without making the scope too big, and we needed smaller transducers and make things more flexible and being able to maneuver. So that those were breakthroughs. And then most recently, the addition of shear wave elastography, especially for liver, but it's not going to stop at liver. It's going to go to pancreas and so on. So that's all on the imaging side. On the intervention side, obviously, the movement from FNA to FNB was a big game changer in terms of getting the best possible tissue sampling. And then the whole access and drainage world.
Yeah, that really took off.
My gosh, starting with rendezvous initially with guide wire placement, and then the lumina prosing stents, choledoco duodenostomy, choledoco, cholecystoduodenostomy, hepatico-gastrostomy, gastrojejunostomy, all of those bridging maneuvers then followed suit, and those are all tremendous breakthroughs that were initially just like, oh, isn't this cool? We could get away with it, and now it's becoming mainstream, you know?
Right.
And then the whole vascular intervention.
Yeah.
I think the ones that are hitting mainstream are the glue and coil placement for gastric varices. The other stuff that, you know, haven't moved forward and spending a good 10 years in the whole anti-tumor delivery space. It's not that we can't deliver, but we don't have the magic bullet yet that is effective as local therapy, for example, pancreatic cancer. Although some of our brachytherapy can be super useful with EUS needle placement of not just fiducial markers, but radioactive seeds. So the drug delivery ablation is not quite the breakthroughs, but definitely the access and drainage.
Right, absolutely. It's impressive to see where the field has come, and then of course to daydream about where the field still has the potential to go. You know, I first learned about you when I was a resident at UCLA. I worked under the guidance of one of your mentees, Raman Muthuswamy, who has since become a very big name in Barrett's esophagus. And then I realized that, you know, or Raman led on that a lot of the Barrett's esophagus stuff was done with you at UC Irvine. And it's kind of put two and two together and figured out who is Ken Chang. And so I got to ask you this, you know, EUS, Barrett's esophagus, is kind of like very different worlds here, right? So after your work on EUS, you kind of like shifted gears a little bit, did you, into the world of Barrett's esophagus? And even then, I guess maybe it's because you're a bit of a daydreamer, you made a tremendous impact on the field. This time on pioneering RFA for the management of Barrett's esophagus with high-grade dysplasia. And again, it's kind of like hitting the same themes here. You know, what was the inspiration for you to bring interventional endoscopy to the world of Barrett's esophagus, and how did this journey kind of come about?
Yeah, great question. As I mentioned, you know, back in '93, I was recruited to be head of GI oncology. So the personal story is that right before that, in 1991, my dad was diagnosed with locally advanced colon cancer. He was in New York at the time. I was on the phone with him one day, and you know, he said, I've been taking iron supplements. And I go, why are you taking iron supplements? He said, oh, my doctor says I'm anemic. And I'm saying, why are you anemic? He says, I don't know. And he said, my doctor did give me these stool cards, but I put them in the drawer and I haven't used them. I said, Dad, I'll hold you. Go use them. So sure enough, it was positive. I said, Dad, you're getting on the plane. You're coming to UCI. We're going to take a look. And sure enough, he had a locally advanced colon cancer, was resected, got chemo, and survived that. But so that was my entree into the GI oncology world, realizing that there's a disconnect between when the gastroenterologist diagnoses a cancer, hands off to the oncologist, and that's it. We kind of end our journey there, and we go on, and the oncologist then takes the patient, and they're thinking about which chemo do I give the patient. And there's so much that's left unmet in that in-between, in that exchange on the pre-cancer, the staging, the treatment, the post-treatment, all the complications from treatment and so on, the obstructions that happen, the nutrition that needs to happen. So that whole world was an unmet need. And so at that time, before I accepted the GI oncology head position, I flew out to New York and I sat with Charlie Lightdale and I asked him about his world as a GI oncologist. I went to MD Anderson and I actually met with Bernard Levin.
Mm-hmm.
And I said, Bernard, tell me about your world as a medical oncologist from the oncology side. And I realized that there's different versions of GI oncology. But I accepted the position because I realized there was an unmet need. So I started my early career motivated by my dad's story and thinking about the whole endoscopic oncology. You know, can we as endoscopists now diagnose, stage, treat, and palliate cancer? The entire spectrum of cancer, can we be a part of that?
Uh-huh.
And can we be a part of not just the cancer, but the pre-cancer and the pre-cancer?
Mm-hmm.
So esophageal cancer, can we be a part of staging and palliation with stents and so on? But can we be a part of Barrett's diagnosis, treatment, and eradication? And then the pre-is, can we be involved in GERD, which then leads to Barrett's, which then leads to cancer? Mm-hmm. So my career has been cancer focused, but the entire spectrum. And that includes obesity as pre-cancer.
Right. Because I'm starting to get a glimpse into your evolution as an investigator, right? From Barrett's to then the endoscopic management of GERD, and then now into the endoscopic management of obesity as well.
Yeah. So I'm going backwards.
Yeah. I'm starting to get a glimpse as to how your mind works in that realm.
Yeah. So back in the day, again, put on our 1990s hat.
Mm-hmm.
If a patient was diagnosed with Barrett's and high-grade dysplasia, the treatment was esophagectomy.
Yeah.
So if you had Barrett's, you got your esophagus. And back then, the mortality from an esophagectomy was 10 to 20%.
Right.
Like, okay, so you get Barrett's with high grade, you can die, 10 to 20%. But anyway, so right around that time, photodynamic therapy was the very first endoscopic therapy that was for Barrett's with high-grade dysplasia. There was a brilliant guy named Gene Overhaul who was in Tennessee, and great guy, gentleman. So I flew out and spent a few days with Gene to learn about PDT. And then I brought it back to UCI and started doing PDT for patients with Barrett's and high-grade dysplasia. Mm-hmm. With great efficacy. Like, we were able to eliminate Barrett's and high-grade with this therapy, but the side effects were horrific. 35% stricture rate.
Wow.
Photosensitivity. You can't go out into the sun in Southern California for like 6 weeks. Otherwise, you get a crazy lobster sunburn. Mm-hmm. So I had brought the PDT into GI at that time. And then around that time, there was a teaching conference. I gave a lecture, and then there was a young ENT surgeon by the name of David Utley. Mm-hmm. And he gave a lecture on some ENT topic, and we became friends. A few years later, he calls me up and says, "Hey, I'm the chief medical officer now for a startup company called BarX. I'd really like you to look at this device that we've developed for treating Barrett's. Because of your work with PDT, I would really appreciate you taking a look at it." So very early on, I looked at their prototype. It was a 360-degree RFA, as you know, right. But at that time it was really crude and barbaric and so on. But anyway, I said, if it doesn't cause the PDT stricture and the photosensitivity, it may have legs. So we did the early trials, we did animal studies, and it looked like it was quite promising. But after doing a handful of patients, we realized, we've got these islands and spots and things that, are still remaining, and it doesn't make sense to eliminate 90% of the Barrett's and still have 10% remaining. And we'd even go back and do another 360, and that same spot would not budge because it was in a little bit of a pocket, or the esophagus lumen wasn't uniformly accessible to the radio frequency 360 balloon.
Sure.
So at that time, we had the same problem with PDT. And I came up with a novel way of treating focally. I used neodymium YAG laser. We were using the laser for biliary stones, but you can attach this sapphire contact probe, and then you can actually soft touch the mucosa, hit the Nd:YAG laser, and the laser would hit the sapphire probe, and the sapphire probe with the intense energy would ablate the mucosa focally. So I use Nd:YAG laser with the sapphire contact probe to do my touch-up, and the patient would reach crimp. So again, based on prior experience, I'm now saying, hey, Utley, we need to come up with a focal device. Otherwise, RFA will not take off. He said, I think you're right. So then we began developing. So then I had a consulting agreement with BarX to develop a focal device. Initially, Utley and the engineers were totally over-engineering. They wanted a hydraulic lift. They wanted, a balloon. They wanted this and that. I said, no, keep it simple. Focal device, a simple platform that can pivot and turn mechanically, not hydraulically. And so we came out from initial discussion around coffee to the first prototype, 9 months.
That's really good.
That's like lightning, right? 9 months until I had a device in my hands, and we were actually doing the clinical trials, and it was working. And that was the beginning of what we now know as the Halo 90 or the BarX 90 focal device, which one uses. But to this day, if you look on the box, it says in parentheses Chang cap. So David Utley and Greg Barrett agreed to nickname it the Chang cap, and I was able to receive royalty for a number of years, but now it's kind of as a out of respect, the name is still on the box. So that was kind of my foray into the Barrett's world. And it's interesting. I mean, there's certain things that I spent 10 years on in terms of anti-tumor delivery by EUS injection, and it's nowhere to be seen today, actually. I spent 9 months on an RFA, and boom, it's worldwide. So, you never know when something will fly or not. But this is one of those things that I'm so proud and happy and honored, and David Utley to this day and I are still good friends.
I think it's very interesting. I think that's I think that might be like a concept in business in general, that major advancements tend to happen pretty quickly without people really realizing how fast it happened, right? Whereas like things where just kind of chugs along for like 10 years, 20 years or longer, there's usually a reason why it's chugging along, right? It's like one of those things that's just kind of, I don't know if this is the right thing, or I don't know if this is going to have that much of a future, etc. Versus something where it's like 9 months. That's when I think with all the momentum, you kind of know this is going to work. Right, I think it's got a very interesting contrast, for example, with say the endoscopic management of GERD, right? Which for many years people have tinkered around with various devices and stuff, and I think we're still trying to figure it out.
Yeah, the GERD space. So I've been involved with the endoscopic treatment for GERD from the ground up. Over 30 years. Over a dozen devices that have come and gone, right?
Yeah.
I could go through the graveyard, but eventually we found something that really worked, right?
Right.
And that's the TIF, transoral incisionless fundoplication,
right?
Which now is taking off. So TIF is a late bloomer. TIF
Right,
is a
right.
late bloomer. But interestingly, so obviously this is another kind of innovation story that must have some teaching points. So this is a device that can endoluminally create a fundoplication and wrap stomach around esophagus to recreate a GE flap valve.
Mm-hmm.
I don't think the company understood that this would someday turn out to be the optimal flap valve reconstruction that best currently mimics the natural working flap valve. And even better than a surgical reconstruction of the flap valve. And what's interesting is that initially our surgical colleagues look at this as, this is never going to make it, and so on and so forth. But as we've collaborated, as we've formed the American Foregut Society, as surgeons and GIs are working in the same space, and this forces the surgeon to see things endoluminally and see what the flap valve looks like as it's being constructed. So now we're looking at Nissen. What does a Nissen look like endoluminally? What does a toupee look like? What does a Watson look like? What does a TIF look like? And so what's interestingly is we are now finally understanding and learning the anatomy and physiology of the naturally occurring anti-reflux barrier now.
Right.
You assume like, oh, we had this figured out. That's how Nissen, came to be. It's not that way.
It's interesting. GERD is surprisingly very poorly understood, actually. It's something I learned very much later in my training.
Yeah, so we're just now unraveling, how our body protects ourselves from GERD, and the G junction truly is a flat valve. Mm-hmm. It's an anatomic flat valve that works even in a dead cadaver, and we're going back and proving all that in ex vivo study and so on and so forth. But it's interesting that sometimes a device comes along and does something, and now we have to reverse engineer and figure out, oh, that's how the natural thing works, and now we understand how it really works. Anyway, so it's an interesting evolution. But that's been one of the exciting things for me in the GERD space, to finally understand the anatomy physiology of GERD, to finally understand why things didn't work in the past. If we knew this, we would have saved millions of invested dollars, and years of work if we understood what we understand now. But now that we understand what we understand now, it's time to innovate on top of solid foundation. Yeah. Absolutely.
Late bloomer, right? It's a bit more of a late bloomer. Speaking of which, what about, I know one of your more recent projects, I guess your most recent project is on endohepatology. That's a bit more off the beaten path here. Why don't we talk a little bit about how this concept came about, and whether you believe this is something that will really take off at some point.
Yeah, I do believe it's going to take off, and actually it has taken off across the globe. If you go to Europe, if you go to Asia, South America, everyone's talking about endohepatology and starting to get on it, especially in the world of NAFLD NASH or MAFLD MASH.
Right.
It's really taking off. So the origin story of this is, again, back in the early 2000s, when we were doing EUS and driving by the liver, 12 times a day, every day, and looking at the liver. In my GI fellowship, I loved hepatology. I even considered becoming a hepatologist. I scored the highest in my liver portion of my boards. For whatever reason, I just loved the liver. So as an endosonographer, not only did I care about the pancreas, but I really liked looking at the liver. And early on, I began palpating the liver with my EUS probe And I would tell my fellow, oh, this is a normal liver. And I would tell my fellow, oh, that's a cirrhotic liver, just based on palpating with
Wow.
the scope.
Wow.
And interestingly, I taught this concept to Marvin Yu, who you know
Uh-huh.
very well. And Marvin, bless his heart, he actually formalized and did a study on EUS palpation. And it's submitted for publication, and he honored me with being a co-author. But and so I won't spoil it, but there is a amazing correlation between an EUS palpation and liver biopsy.
Very
But
interesting.
yeah,
It makes
so
sense. It really does make sense.
yeah, so anyway, so that was my first endohepatology thing. And then, with EUS FNA going to FNB, I think it was in 2016 that we published the first case of EUS FNB diagnosing autoimmune hepatitis. So we used the FNB needle to biopsy not a focal liver lesion, which was published earlier, but just into the parenchyma and getting a good sample. And we found that we had decent cores, not but passable cores. And then that began a journey of trying to get better and better and better cores, and trying to convince our hepatologists, who are not an easy crowd to convince to do anything, or just to change their ways, to accept EUS liver biopsy as a reasonable alternative. Today, in our institution, that is the predominant preferred modality for liver biopsy, because we can give them 20 centimeters now,
Wow.
with greater than 15, 20 complete portal tracts, consistently. And so this is now the go-to for liver biopsy. So so we had imaging, we had this palpation thing. We can detect the ascites even before CT. So back then we were starting liver biopsy. So in 2012, I published a kind of a white paper on a new paradigm, endohepatology. I looked at all the things that we were currently starting to do. We were starting to do liver biopsy. We were able to detect ascites. There were series looking at EUS paracentesis, right? We could use EUS to look at and diagnose gastric varices. There were reports in animals of EUS tips. And then the only thing that was kind of missing was EUS portal pressure gradient measurement. And so working with in the animal lab first, we first determined that yes, you can put a needle into the portal vein, and you can put a needle into the hepatic vein. And then we went to radiology and cardiology, borrowed these very expensive wire-guided transducers that were very delicate. And if you pass a 19-gauge needle into the portal vein and pass this wired transducer in, you can measure the pressure of the vessel. But that was expensive, and these wires would shear easily. And we looked at water perfusion manometry systems, which were clunky. You needed almost like to shove an ERCP catheter through the portal vein in order to do that. So then finally, working with Cook, I said, hey, can you guys make me a simpler pressure gauge that we can attach to a needle? I said, hold on a minute. In their reproductive health business unit, they had a pressure gauge.
Oh.
Yeah. This pressure gauge was used for in vitro fertilization. They transfer the eggs. They need to make sure that there isn't, as they transfer the eggs, they can't exert enough pressure to fracture the eggs. So this pressure gauge was there to make sure that wouldn't happen.
Oh, interesting.
So then they said, do you think you can use this? And I said, let's give it a go. So we did some animal labs, and it was perfect. We used 19 gauge needle. We got great pressures. We went to 22 gauge, fine. And I said, hey, what about 25 gauge? And it was just as good as the other sizes. And now you've got a tiny needle, that doesn't require water perfusion. That's a handheld, simple, disposable pressure gauge. Hook it onto a needle with a non-compressible tubing, and off you go. So in 2016, we published our animal series. 2017, we did our pilot study of 28 patients and published that in GIE. And so once we had that, then, what I wrote in 2012 about endohepatology, then became even more of a reality.
Right.
And then since then, EUS-PPG is multi-center trials and lots of data now. And now shear wave elastography is available on the ultrasound processors so that we can image and assess the stiffness of the liver, right lobe, left lobe, which percutaneous you can't, and spleen, which percutaneous you can't. Spleen stiffness is what MR elastography has as an advantage. Now we have that same advantage, right lobe, left lobe, and spleen. And it doesn't matter if the patient is obese or thin. There's no interference, obviously. So we have better, more accurate stiffness assessment of liver and spleen, because there are things in the liver that can artificially mess up your FibroScan, right? If there's inflammation in the liver, if there's a lot of fat, it makes the FibroScan numbers maybe underestimate or overestimate. But with EUS shear wave, a lot of that is not, those limitations are not there. So now we have imaging, all the above, and then we have vascular intervention with glue and coiling, and we have PPG. So everything that we talked about in 2012 as possibilities became reality.
This is yet like another example of what Ken Chang touches turns to gold.
I don't know about that.
The daydreamer.
It doesn't work for my investment portfolio, though.
That's because you're spending your time dreaming about being inside the GI tract. So then what do you predict will be the next major advancement then in interventional endoscopy?
Yeah, that's a good question. So, I think AI is going to be all over the place with us.
Right.
From imaging enhancement to telling us where the polyp is and diagnosing the polyp type, to diagnosing high-grade dysplasia in Barrett's, so all the image enhancement, AI will increase our expertise artificially. And then all the process things within, the endo unit will be AI driven. Being able to diagnose patients by incorporating what did the esophagram show, what did the CT scan show, what do the labs show, and AI is going to tell us and guide us along. So I think that's pretty clear to me in my alternate universe that AI is going to take us there.
Sure.
Yeah, I think robotic endoscopy also has legs. I don't know if it's soon. I don't know if it's going to be pervasive, but there will be segments of GI endoscopy that will become robotic. And so then that'll be in the purview of surgeons as well as interventional endoscopists that will be able to go in, have two hands, have triangulation, be able to lift and cut and all that. So your resection world, I think. So I should throw this question back to you. But anyway, so I think robotics. Yeah, I think robotics is the future. I think the resection world, again, you're the expert, but I think we've moved from EMR to ESD. And initially, so back in the day, we published about EMR in the early 2000s, and everyone said, and the title of, so Roy Satikna, who's my fellow, published a white paper on EMR in the West, making an argument that, hey guys, EMR is not just an Asian thing. it's coming. At that time, people didn't think it was going to take. Obviously, now we're all doing EMR.
Right.
That's the same paradigm for ESD. Initially, they're like, okay, we'll do EMR, but we'll never need ESD. We'll never do ESD. Well, today, it's like, yeah, all the papers are showing that wider margin, en bloc resection is the way to go. So now we go from EMR to ESD, and then EFTR, endoscopic full thickness resection, for GIST and leiomyomas and all of that.
Right.
That's emerging now, and then going out through the GI tract, harvesting lymph nodes and closing up. That's around the corner. So I think those are some future things that I think we all clearly see that's around the corner. But I think the other aspect, so innovation has kind of two definitions. One is, a new technology that, like we've been talking about in this entire time.
Right.
But the other aspect of innovation is scaling, right? Scaling it so that more physicians can do it, and scaling it so that more patients have access. And both are unmet needs, right? There are very few, Phil G's who can resect like you, but can we look at a day where a general GI fellow can do a resection,
Right.
and it's, so that's innovation, right? And
right.
And then if you look at disparity and ethnic disparity, I would say if we look at how, what is the ethnic racial disparity for getting an ESD when an ESD is needed, I bet you it's pretty dramatic,
Yeah.
So accessibility.
It's very interesting you bring up the accessibility and scalability, because those, to me, are some of the sort of the X factor in terms of whether a technology ultimately takes, or whether an technology is ultimately viable, because those are concepts which then kind of lead into the business of medicine and the business side of innovation, right? Because if something is only limited to a very few number of experts, like say yourself, right, or a very, very small niche, that may not have as much of a viable business future as something that is broadly applicable, like say EUS-FNA, for example, right? So I think that in itself is, you kind of touched upon. It's a very important concept in innovation, is not just the dreaming, but also the practicalities and the business realities of innovation. But there's also a training reality too. I kind of wondered to myself, I was an advanced fellow not that many years ago. It was 2017 to 2018. And even then, it was very difficult to learn what I wanted to learn in the course of a year. And arguably, I credit Raman Muthuswamy in UCLA with having given me a head start on that. And, I kind of want your take on this. With such a broad field, it's increasingly impossible to train fellows on every aspect of interventional endoscopy. What do you think the field has to do about this problem?
Yeah, so these are questions I think about constantly. I think our training paradigm does need to change. I don't, the traditional 1 year EUS ERCP and then go out there. That's just the beginning. That's right. Kind of like interventional endoscopy 101, right? So I think, and then, so it's impossible, right, to do EUS, ERCP, master resection, all the GERD technology, endohepatology, endobariatrics, and, all in 12 months. Right. Just absolutely impossible. No one can do that. So one way is to kind of individualize the training to what the fellow wants to be able to master, what the institution is capable of training them, and how long it would take. And so we have a modular, we have 2 to 3 advanced fellows each year, and we have a modular approach where it's 12 months if you want to do EOS RCP only, maybe some EMR and RFA. 18 months if you want to add something else, like bariatrics, resection, GERD, and if you want everything, 2 years.
Mm-hmm.
2 years. So that's one way to kind of adjust things.
Yeah.
The other way is to create more focused tracks. So we're developing a 1-year track on interventional foregut. So you don't have to learn ERCP, right?
Oh, I see.
But endoluminal, you master manometry and endoflip. You do poem, E-poem, Z-poem, G-poem. You do GERD, right? But you do EUS, but you don't need to do liver, pancreas, ERCP. And so and that can be through GI internal medicine, and that could be through MIS surgery.
I see.
Foregut interventional kind of track.
Mm-hmm.
So that's an interesting paradigm too. And I think and that's why we created an institute, because in our Digestive Health Institute, suddenly the walls of being Department of Medicine versus Department of Surgery come down.
Uh-huh.
And so surgical fellows can cross over and work hand in hand, day to day with GI advanced fellows, and there's less of a separation of those two.
Yeah.
And that's the whole concept with American Foregut Society. We're trying to break down the walls, and eventually we'll have training that is the surgical interventional hybrid, where, most or many of the interventional endoscopy development have been in the hands of surgeons, right?
Right.
If you think about Nib Sahendra was a surgeon, the Hong Kong faculty, Phillip Chan, Anthony Teo, Shannon Chan, they're all surgeons, right? They're foregut surgeons. They're general surgeons who do mostly endoscopy. In Europe, we're seeing the same model, not so much in the States. Right. So I think training has to shift, because having this artificial wall of surgery and medicine just doesn't, it's archaic, and it slows us down.
It's very interesting, actually, because in a recent interview, Peter Cotton actually talked about the exact same thing, about starting a comprehensive digestive health institute over at MUSC. And so let's talk about you then. So you're currently the executive director of the Chow Family Comprehensive Digestive Disease Center and of the Digestive Health Institute. And I know from personal experience from your fellowship courses and stuff that you run, that you are tremendously proud of this center, and you should be. Tell us about your center, and tell us about the Chow family, actually.
Yeah, another origin story. Yeah, so when I started in 1993, I was head of GI oncology, and I spent a decade, 10 years, in the cancer center. And so in those 10 years, down the hall was rad onc, down the other hall was surg onc. Everyone was something onc, right? Mm-hmm. And I love the culture. I just love and I was at tumor boards all the time, and the dialogue and the exchanges were phenomenal. And I hadn't seen that previously, right? And so in 2003, we spun off the Digestive Disease Center, trying to create that same culture, that same integration, knocking down barriers of departments to create a digestive disease center. And that was inspired by Peter Cotton. Before launching the center, I spent time with Peter. I went to MUSC. I talked to Peter. I said, and at that time, he had just started MUSC's Digestive Disease Center. Mm-hmm. It was called DDC, right? Digestive Disease Center. And so he shared with me all of his growing pains. He shared with me his stumbling blocks and what worked and what didn't work. I took all of that to heart, and we started our CDDC, Comprehensive Digestive Disease Center. But one of the things that he underscored that could make or break you was not money, was not brick and mortar, it was people and egos.
Yes.
So if you try to take an established center and create a digestive disease center, you're likely to come up to ego issues because the chairs of the different departments say, well, why would I do that? Why, and because you release authority by having this new integrated entity, right? Mm-hmm. But I had the fortune of starting from the ground up, right? We had nothing. We were one person, one room, and we started with nothing, and we just kept building, and I kept recruiting surgeons and adding until we became a truly robust center. And that was only possible with the additional support of philanthropy. Mm-hmm. So that's something that we're not taught in medicine, the importance of cultivating philanthropy. And it's not so much going out with a handout for a handout and begging money. It's understanding what passions patients have, whether it's gratitude, whether it's frustration, whether it's death in the family, that motivates them to want to push the envelope. Mm-hmm. Once we understand their passion, and if it aligns with your passion, then it's a win-win. Yeah. So understanding that, my first connection with the Chow family. So the Chow family are first generation immigrant Asian family from Taiwan. They were in the pharmaceutical business in Taiwan, and they had a factory in China. And they came to Orange County and started Watson Pharmaceutical, which was a generic pharmaceutical company. Mm-hmm. So the name Watson was transliterated from the Chinese characters, and it was
interesting.
Named Watson. So Grandpa Chow, I wound up taking care of when he was in his 80s, and then the next generation, who are now in their late 70s. I took care of them when they were in their 40s and 50s and on. And one of the siblings was diagnosed with gastric cancer, and he's already shared this publicly and with permission. I took care of him and eventually got him in remission and cured. And so the family then became very grateful, and they realized that the epidemiology of cancers amongst Asians in the United States was very different than the mainstream population. Mm-hmm. So, for example, if you lived in Asia and you're 50, you're likely to have had a screening endoscopy.
Right.
That same person in California is not, and insurance won't pay for it.
Right.
Right. So they understood there was an issue. They understood that their community didn't have any awareness. Didn't know that they were missing out and, not getting properly screened and so on and so forth. So then the Chow family said, okay, we're going to support the Cancer Center, and we're going to support the newly established Comprehensive Digestive Disease Center to help our community, both Asian and non-Asian. We want to help the community, give back to the community, which is unheard of for first-generation Asian immigrants to give at the first generation, maybe right. Second, third, fourth, but it's unusual. So hats off to the Chow family. So they've been supporting UCI from the beginning. Wow. The Cancer Center, the Digestive Disease Center. We have a new campus, and they supported the second Cancer Center on the new campus and so on. So they've been tremendously supportive. And I have the privilege of taking care of Grandpa Chow, the 4 siblings who are in their 70s now, the third generation who are in their 40s now, who are many of them are successful physicians, business people, and now there's a 4th generation who are in their teens and high school. So 4 generations of Chows. I've had pleasure of essentially feeling like part of their family. We get together and I keep them updated. So that's been a tremendous relationship. So then 2 years ago, the dean wanted to elevate the center to become an institute. So this had to go through the vice chancellor, the provost, the chancellor, and it got approved. And so then we became the UCI Digestive Health Institute. So now we're not just a physical building with 30 specialists across all different disciplines. Now we've become countywide, 2 main campuses, multiple satellites, about 55 faculty, all working in the Digestive Health Institute.
Wow.
So we finally reached the kind of final evolutionary step in going from a program to a service line to a center to an institute. And so now I report to the dean and to the CEO of the hospital, and we're trying to also break down the walls between school and hospital, right? Which so
that's incredible. It's an absolutely outstanding relationship. It's one of those things where, like you talked about, it's something that's very little discussed in our medical training, but actually has a very, very outsized value that some people may realize later on, and certainly brings benefits to both sides. I think it's also kind of interesting. You alluded to this a little bit, that UCI being a relatively small institution, you've had it has come with tremendous advantage to you, actually, to have remained at UCI your entire career, at being at a relatively small institution, and then where you've had the opportunity to then kind of mold that, right? Like kind of build the entire institute, and then it probably has paid off dividends in terms of impacting your academic productivity and your ability to be a pioneer and supporting your ability to become a pioneer. What would you say there's some truth in that?
Yeah, I definitely would. I mean, sometimes people come and visit and say, "Oh, it was wonderful that this was all handed to you," and quite how it happened.
Never mind.
But yeah, so I think there are definite benefits in staying put in one place, and that leads to loyalty, continuity, trust, credibility, right? But I've gone through multiple renditions of the C-suite. I've gone through 4 deans, 4 chancellors, a number of department chairs. So as the leadership revolves, you do have to reestablish that credibility.
Right, of course.
But overall, there is a definite advantage. Obviously, I've had offers along the way, recruitment efforts. Not that I would look out, but I would get tapped. But my reason to stay is that whole sense of continuity that I kind of built it from the ground up, and as much as I want to be loyal to them, they've been loyal to me. So a lot of our nurses have been there for 20 plus years. A lot of our staff have been there. A lot of our faculty, I trained as fellows, and now they're full professors, or, I've helped lead them for 20, 30 years. So all of those are real advantages to staying. Now, of course, I'm not saying that staying is always the right answer, right? Obviously,
right.
When you consider moving to a different institution, there's 2 aspects. There's the pull, like, there's this opportunity at the new place, or that opportunity that you didn't have. So there's the pull and there's the push, right?
Right.
And sometimes it's more the push. The politics are overwhelming, whatever it is, there's a push and there's a pull. So I always look at the push and the pull. I try to put my ego aside, and the push and pull incorporates obviously your career passions, and that changes in stages of your career, but it also very importantly includes family and friends and community. So that's an important factor. And some of those were the anchoring for me, and the anchor points to not move was because of family, friends, church. Those were all part of my community that if I were to relocate, that would change the dynamics there.
Absolutely.
So it's a combination of that and, a work environment that was very trusting, and, I could do these semi-crazy things, but they would trust me that I have a track record of doing things intentionally, incrementally, and with great thought. So I think that speaks to staying. But yeah, it's unusual for someone to hang in one place.
Very unusual.
35 consecutive years.
Yeah, but I mean, I think the accomplishments speak for themselves. It definitely was not handed to you. Your legacy on the field as a result of all this is immense. What do you regard, if you were to look back and say, what do you regard as your most proud accomplishment to the field?
Staying alive.
Yeah, that's good enough.
So actually,
that's a good one, though.
I'm kidding, but I'm not kidding, right?
Yeah, that's a good one.
Yeah. So, I never considered myself as like super talented endoscopist. I was a plotter. I would be very diligent. I would work hard. I wouldn't get it lightning speed, but I would eventually get it.
Mm-hmm.
And so what's very interesting in the world of endoscopy is it's not a race, right?
Right. It's a long game.
It's a long game. And the only way to stay, and what's interesting is, as experience builds, your contribution to the field seems like snail's pace at the beginning of the career, and then it picks up in your mid-career, and then it accelerates in your last third or last fourth. Like I'm accelerating now at age 64, going to 65, right? So it's interesting. Your return on investment accelerates in the last phase of your career.
Right.
But if your health gives out midway, you're done.
Right.
If I knock out my back, staying alive there's some truth to that, in the sense that you want to keep healthy, right?
Yeah.
You don't burn out early on in your career. It's the long game. So sleeping well, eating well, exercising, and ergonomics. Like we never talked about ergonomics early on.
Right.
And people go out with back injuries, shoulder injuries, neck injuries,
radiation injuries.
Injuries. Right. So all the fellows know when I'm in the room, I spend a good few minutes adjusting the height of the monitor, adjusting the height of the bed, making sure my body position is good, making sure I'm not slouching, wearing, good shoes, stepping on a mat. All of that is important for our longevity.
Mm-hmm.
And the fact that this 64-year-old guy can do poems and all these, crazy and long procedures. And to get to that point, you have to have years of experience to build on,
right?
Until you can integrate all of these different techniques. So because it takes so long to get there, you got to stay healthy enough to enjoy it. Yeah. So
no, absolutely, and
that's one proud achievement: staying alive.
Yeah, and actually, that's actually probably some of the best advice that I've heard in all of these interviews as well, and kind of brings us to sort of the close of our interview. It's been a tremendously enlightening interview. And as per usual, we've obviously crossed paths many times, but I've learned so much from you, and I'm so grateful for your mentorship over the years. But what advice would you have for future generations of pioneers who want to do something similar to what you've done, something disruptive, something innovative, something pioneering in GI endoscopy. I think we already know one of them, which is stay healthy, right? Staying alive and staying healthy and taking good care of yourself. That's something actually like I'm pretty serious about too when I talk to my fellows about it. What are some of the other ones that some of the other pieces of advice that you would have?
Yeah, I think we touch upon this, and this is something I really appreciate about you, Phil, is always keep a learning posture. Like this interview, the whole time you were taking a learning posture, you're an expert yourself, but you've decided to take a learning posture to gain something from this person that you're interacting with great respect. So I'm always taking a learning posture. And even when I'm interacting, or especially when I'm interacting with my fellows, I'll ask them the question, like we're in the middle of a case, and I'll turn to them and say, what would you do? And, they freak out. They're like, wait, why is Ken Chang asking me what I would do? Right? Is this a test? Right? And I don't let on. It's like, do they think I don't know, or do they think I do know?
Right.
Am I testing them, or I'm really like, scrambling and want them to give me input. So I don't let on whether I have an answer. I don't ask it, hey, what do you think? And they'll give me their thoughts, and I'll listen very intently, not only to the answer but to the thought process behind it. Mm-hmm. Because sometimes the young perspective has some clarity and truth that we may have overlooked. Another thing I learned way back from Charlie Lightdale, who's now retired. When I was a young faculty, when we went to meetings and so on, I would bump into Charlie, and he was like the god of endoscopy and so on.
Right.
But he would remember my name. He said, "Hey Ken, how you doing? How's family and stuff?" So that's the usual. And then, there was one time we were washing hands in the men's room, right? And he looks over to me and he says, "Hey Ken, how you doing?" I said, "Oh, good, thank you, Dr. Lightdale." He said, "Hey, what have you been thinking about lately?" I'm like, Charlie Lightdale's asking me what I'm thinking about lately? Mm-hmm. I'm like, oh. I said, well, Charlie, I'm really excited about this FNA, FNB, FNI thing. And he said, oh, tell me more about that. So I was like, wait, is he like, just giving me a chance to talk, or he really wants to learn from me? And I think he really wanted to learn from me. Right. So I think one of the advice for young faculty fellows is keep a learning posture. You never master it, right? You're always learning from others. The second, I think, is a theme throughout our conversation is innovate out of compassion. Don't innovate out of I want to be a first author and I want to whatever. The right reason to innovate is the patient has a problem and you're trying to solve it, right? So innovate out of compassion. Don't get greedy. Don't hoard. Always share. The universe has a way of returning things to you. So always, kind of give it forward and don't be greedy. Share ideas, share victories, share trials and tribulations.
Absolutely.
And more than ever, work as a team, as a community.
Yeah.
The point of work is your colleagues, that will transcend time. And if I think back at a very, very fortunate, blessed career, wildly more than I ever would have imagined my career to be. I never aspired to be a chief or an institute director or anything else. I wanted to be a missionary, as my formative mentors were. I just wanted to help people in the best way possible. So I'm losing my track for a second.
Humility.
Yeah. So that's right.
Humility and compassion.
Humility and compassion. Yeah. Yep.
No, I think on that note, this has been a tremendous interview. Thank you so very much for taking the time to provide this interview and for having a really wonderful chat. I've learned so much about you and so much from you over the years, and I look forward to seeing this in the next issue of IGIE. Thank you again, Dr. Chang, for everything that you've done.
Thanks, Phil. Thanks for doing this. The genius of your questions, the thoughtfulness behind each one, and your gift to be able to elicit these deeper thoughts and motivations is very much appreciated.
Thank you very much.
All right, Phil.